Good afternoon, and welcome to Wednesdays at the Center, hosted by John Hope Franklin Center and Duke University Center for International and Global Studies. Today, we are pleased to welcome Mr. John Bartlett, Ms. Patricia Odero, Ms. Lavanya Vasudevan, and Duke Master students Carl Mhina and Alex Gabagambi for a talk titled COVID-19 in Africa. So please remember to mute your microphones muted and to submit any questions and comments into the chat.
Okay, thank you, Kevin. So my name is John Bartlett, and I serve as co-chair for the Duke University Africa Initiative. Today, we're going to have a discussion of COVID and Africa. This presents us with many vexing questions, such as what is the true prevalence of COVID on the continent? Why has the impact of COVID been seemingly mild? What are the political and policy factors impacting COVID? What treatments are available for COVID in Africa? Are vaccines available? And what are the obstacles to scale up of vaccinations? So today, we're quite fortunate to have four experts to present their perspectives for approximately 10 minutes each. And then we will open up for discussion with the audience. Our first speaker is Dr. Carl Mhina, who is a medical doctor and has a master's in public health from the University of Cape Town. Carl is currently a master's student in population health sciences at Duke. Our second speaker is Dr. Alex Gabagambi Alexander, also a medical doctor who was providing care to persons with COVID in Tanzania until August, when he joined Duke as a master's student in population health sciences. Our third speaker will be Dr. Patricia Odero, a medical doctor who has her master's in business administration and is based in Nairobi, Kenya. Patricia is regional director for innovations in healthcare and the Duke Global Health Innovation Center, and she is going to discuss vaccine availability. Finally, Dr. Lavanya Vasudevan, assistant professor of community and family medicine and global health at Duke, will discuss vaccine hesitancy. Lavanya has led studies on this topic in Tanzania and in the United States, and is supported by the National Institutes of Health and the CDC. So, Carl, perhaps you can get us started.
Thank you, John. I'll kickstart and sort of set the scene. So as John introduced, my name is Carl. I'm currently an MS in the Department of Population Health Sciences, and I'll go through the epidemiology of COVID-19 in Africa and some of the complicating factors, and touch on a personal experience on being an international student here in the United States and having sort of a reflection of what things happening at home. To kickstart, we'll just a little bit of a highlight of what's our current global situation. And it's important to know that we are just above 200 million cases, 5 million deaths. And United States, India, and Brazil have been hugely impacted in terms of cases and deaths as well. And I wanted to share this global situation graph by the WHO. We've been through a number of waves, and you can see here there are changes of cases of weekly, but seeing things going in this linear graph here, we see we're still in a safe place. We're in a safe place, but we're not out of the bush yet. And it's still important to be cautious and think more about ways to control the pandemic, both in country and in the global sense. In this slide here, I really want to talk about how the motherland sort of performed when it comes to COVID. The current situation in Africa is we are sort of just above 8 million cases, 200 million deaths. And at the moment, right above 78 million tests have been done in Africa. Some of the countries that have been hugely impacted are South Africa, Tunisia, Egypt, Morocco. Right here is a sort of top 10 countries which have been impacted in terms of deaths in particular. And we see countries that have been hugely impacted is sort of countries which are hubs to travel, which have high mobility, in particular South Africa. We see here Ethiopia, Kenya. But another thing that I wanted to touch and speak about is issues around human migration and refugees as well. We see Libya, Morocco, Tunisia, right around the Mediterranean, which are hugely impacted in North Africa. On the far right top corner, I wanted to touch on what's the contribution of Africa and sort of how has Africa been impacted compared to other global regions. And the orange contour here represents Africa in terms of cases, and here Africa in terms of deaths. So we see Africa has not sort of had a huge impact or have been lowly impacted by COVID in terms of cases and deaths. But there are sort of complicating factors when we speak about Africa. One of the biggest questions epidemiologists and sort of public health and everybody has had is really how many people have had COVID or have COVID-19 in Africa. We see fewer than 50% of COVID-19 cases in African countries are currently correctly reported. And this graph here by parts, as well data from the WHO, shows COVID-19 tests administered per 100 people. We see Africa has 5.14 compared to 170 and 412 in the US and UK respectively. So people have more than one test, 4 tests, while in Africa, we're speaking about 5.4 people out of 100. Other areas that are quite complicating in Africa is we've heard a lot about the population age and structure. Currently, 91% of infections are in people who are below 60 years of age, and deaths in males more than females. And we spoke a lot about the youth population and its impact on COVID-19 and the low numbers of COVID-19 in Africa, which we'll see more. But here, I want to talk about some of the issues that were sort of forecasted or predicted to be complicating factors in Africa. Another thing is health system. There was a fear of weak and under-resourced health systems in Africa, and earlier estimates by WHO showed there are 9 ICU beds per million people in 47 countries in Africa. But we've seen the experience in Africa in terms of HIV, AIDS, and Ebola play a major role in terms of controlling of the pandemic. Another issue was the urban situation, where we have cities with high population density and informal settlements as a big worry of COVID transmission and people getting COVID, particularly when we talk about social distancing and other control measures like lockdowns. Another thing is the biggest urban population in Africa is mainly in informal gig economy. So there was sort of a trade-off, should I work or should I stay at home? That was one other complicating factor when it comes to COVID-19 in Africa. Another issue is comorbidity. And these are some of the sort of estimates, adjusted hazard ratios of comorbidities. This is a study done in the University of Western Cape of 3 million, a cohort of 3 million people, and they followed them for a certain period of time. So they saw that people with HIV had an adjusted HR of 2.14, and people with current and previous TB had 2.7 and 1.5 respectively. So there's an issue of comorbidity being a complicating factor. And finally, I wanted to touch here, sometimes we speak about the epidemiology of COVID-19 in Africa and trying to sort of focus on certain measures rather than focusing on other measures which are quite important. It's like almost trying to making what we measure important rather than measuring what's important. And when it comes to impact in terms of the demographic dividend, there are other things that we really need to look at in Africa. One of the biggest things is disruption in healthcare systems based on demography. In the far left top corner, we see the disruption of contraception for adolescents and young adults in Nairobi. And we see more than around 20% of young men and women have fear of being infected with COVID-19 at healthcare facilities. So there sort of that disruption as a factor of accessing contraception for adolescents. On the far right corner, we see a loss of employment. And on the far right here, we see the poorest 50% had a 31% loss of employment, while the rich 25% has had zero loss of employment. On the left lower corner here, we see some of the health services and outcomes that have been impacted. And I'll touch about mainly barriers to getting food. We see people in the DRC, 80% had had lack of access or barriers in accessing food. In Kenya, 81%. So these are some of the things that we really need to think about when we think about the long-term impact of COVID-19. On the far left lower corner, I want us to see the total duration of school closures, and this is by UNESCO. We see in Africa, schools were closed for less than, let's say, 11 or 20 weeks, while in the US, schools were closed for more than 41 weeks. But there's sort of a limited access to alternative forms of getting education and training, which is really something to think about as well. And one of the things that UNESCO also reported is there's a risk of about 5.8 million Africans not going back to school after COVID-19. And finally, I'll touch on my personal experience. And I just came into the United States a few months later, lockdown, the pandemic, having to work at home with my family and young child, having to balance that, but as well having time to bond with family, having a young one on the way as well. But one of the biggest things was being away from home and trying to inform parents, trying to inform our sort of family back home on ways to control and them being surrounded by the pandemic, and also speaking with fellow colleagues and peers on how to control the pandemic throughout the time. So I'll end here, and asanteni.
Thank you, Carl. Okay, Alex, you're next.
Thank you. As I've been introduced by Professor John Bartlett, my name is Alex Alexander. I will be taking you through this part of clinical perspective of COVID-19 as far as East Africa is concerned. And I will talk much on what was just happening in Tanzania. Going back and try to see how the screening and the triaging protocol was just ensured in Tanzania by the time when we had COVID. We had some things which we had to put into consideration, like the screening was done at the entry point at each hospital around all areas which were receiving the COVID-19 patients. And the triage was done very quickly to identify the patients who needed the emergency care based on the disease severity. And during that time, we had to ensure that the privacy and the confidentiality were to be maintained, that no matter the fact that we had many patients of COVID, of which initially there were few patients, but with the time they were increasing, still we had to maintain the privacy and confidentiality of the patients whom we are receiving. And another thing was the primary goal was to slow down and stop the transmission by case identification, sorting, and test every suspect of the patients whom we are receiving. And the patient's condition were stabilized at the level of the hospital which received the patient. And if it happened that they were not admitting or they could not admit the patient, they were to refer to the designated area. And we had different final location of patients depending on the severity of the disease, whereby we were having the designated hospitals like the National Hospital, Muhimbili National Hospital, Aga Khan and other areas which were just receiving some of the patients who are critically ill and very seriously ill. And if it happened that the patient was was having mild or moderate COVID infection, those patients were treated and then they were allowed to go back home. And another things which we are ensuring at that moment was to emphasize the health care workers and the patients to use the personal protective equipments to ensure that the transmission was going to be prevented from one person to another person. And we had different modality on how we were classifying this COVID infection at our locality, whereby we had 3 forms. We had the non-severe form, which was just including all patients without severe or critical COVID symptoms. And we had severe patients who had severe clinical symptoms, like which were including pneumonia, and they were presenting with the desaturation and respiratory distress. And another type of severity, we had critical patients, whereby this one were having acute respiratory distress syndromes, and sometimes you find the patient was presenting with the sign of sepsis and the acute thrombosis. So those were the means on how we were classifying the COVID infection at our locality. And we had a different method on how we could investigate by the time when we received the patient. The first investigations were the basic investigation, and we were having the specific investigation. The specific investigation were including the nasal or oropharyngeal swab for COVID test. And we had to do the septic workup, because having COVID infection was not preventing the patient from having other clinical symptoms or clinical diagnosis. And we had to do chest X-ray based on the clinical presentation of the patient, serum electrolytes, liver function test, renal function test. We had to do echo, PT-PTT, CRP, which is just the for acute phase reactant, and we had to do chest X-ray. We had to do chest CT scan. This one was not found in most of the areas, whereby those patients who were referred like to the National Hospital or to the higher private centers like Aga Khan and other areas, they were to do this chest X-ray to find out if it was really COVID and how it has been affecting the pulmonary system. So apart from the investigation which we are just doing, we had a different kind of modality of managing this patient, whereby we were managing these patients based on the condition which they were just having. So the first way on how we were just managing this patient was with those who had non-severe COVID infection, we were just monitoring them normally and stabilize them, as I've said, by giving them the antipyretic, vitamin C, vitamin D, and zinc sulfate and prednisolone. These were just targeting the affected systems. And at the end of the day, if you find that the patient was clinically stable, now you can allow him or her to go back home and cancel on the necessity of isolating himself or herself and ensuring the COVID prevention protocol so as to prevent the transmission of a disease from one person to another person. And with those who are having severe and critical COVID infection, we were managing them accordingly based on the clinical presentation. If they were desaturating, we had to give them oxygen therapy and ensuring that they were receiving other medication like the IV corticosteroids, the anticoagulants, and the antibiotics. And we are keeping them on PPI, proton pump inhibitor, and some of them were admitted in ICU based on their condition. So there were some of the challenges which we are just facing during that time, whereby we had no sufficient protective equipment, personal protective equipment in many health facilities. As we can see during that time, the surgical masks and other equipments for protections were not sufficient, and most of the hospitals were running out of it, not only in Tanzania, but also in Kenya, Uganda, everywhere it was just reported. So most of the healthcare workers were faced by this challenge, and they had to improvise some time to find the way now they can work by using the local made mask to prevent the transmission to the patients, and sometimes to prevent transmission to themselves. And we had a big problem of drug scarcity, whereby those drugs which were used for non-severe and severe treatment of COVID, as you can remember that we had no the definitive treatment for COVID initial, of which those suggested drugs which were suggested initially, it happened that most of the hospitals were just buying them, and that was the moment that we were running of shortage of those drugs. So we had a big problem of drug scarcity at that moment. And we had a shortage of human power. Doctors, nurses, and the pharmacists were not sufficient at that time, to the extent that most of the hospitals were running out of staff, and it was really challenging. And we had the poor structure for emergency and critical care, like most of the areas which were receiving the patients. We had a few number of mechanical ventilators, and we had a few number of oxygen cylinder. That was the time when most of the hospitals were running out of oxygen cylinders, like KCMC, Muimbili. There was that moment when they had many patients and they could not support them by giving them by ventilating them as they were required. And we had limited health facilities around the areas, and we could not build new hospitals at that moment. So we had to select some of the areas which were pinpointed to receive some of the patients, and those patients were treated accordingly. That's what was happening at that moment. And we had also poor support from politicians in some circumstances, whereby the doctor or the professional were saying that for the purpose of preventing transmission of COVID infection, peoples were to adhere with the COVID prevention protocol. But unfortunately, you find that some of the politicians were against it, to the extent that we could not maintain the professional protocol. So talking about the experience based on East Africa or Tanzania and USA, you can see that there are a big difference between East Africa countries and the USA. As here in USA, they are having the currently and the previous, they have been having the screening program of every citizen every week. Every person is screened to see if he's having symptoms of COVID, and they usually intervene very quickly based on the condition of the person. But they are back home in East Africa or Africa in general, that one is not happening. And another things which we are just facing in Africa there is the fact that we are not having equipment for fighting against COVID, and we are not full funded to the extent that we can fight this disease to its full extent. And this has been limiting some of the professional and some of the people who are dealing with the COVID prevention to the extent that we cannot go on, and we usually need or seek for assistance from abroad so as to fight this disease. Another thing is the direct interference from politicians to professionals who are doing their jobs. Most of the time they are doing the work they are supposed, but there is a limited number of supports from politicians, as I've said, and there is no sufficient health facilities in Africa in general and in Tanzania as far as our case study is concerned. Thank you.
Thank you, Alex. Okay, now we switch to Patricia.
Thank you, John. So as John shared, I will be presenting on the status of the vaccine rollout, and we'll be sharing some data from our institute, the Global Health Institute, the Global Health Innovation Center, that has been doing some pioneering work around advanced purchasing as well as other metrics on COVID-19. And I'm based in Nairobi, Kenya, so hamjamboni from Nairobi. And so the first thing I think that wanted to share is that at the end of September, the WHO reported on the countries in Africa that had met their 10% target for fully vaccinating 10% of their populations. And sadly, only 15 African countries had met this target. And I think some of the common factors from this list is those were the higher income countries. So you can see Botswana, South Africa represented there. And then small island nations also predominate this list. And also, around that, also countries with relatively low populations. And so the majority of African countries had not met this target. And a month later, then the WHO then was tracking, which countries are on track to meet the next target, the next global vaccination target, which is 40% of the population fully vaccinated. And sadly, about only 5 countries out of the 54 countries on the continent will be able to meet this target by the end of this year. And so essentially, whilst quite a number of high-income countries are at 60% or above of their populations fully vaccinated with booster doses being rolled out, the situation in Africa is quite grim. And so this presentation looks at some of the factors that are impeding vaccine rollout. So I will focus primarily on the supply side factors, while then the next presenter will then look at some of the demand side and population-based factors. So I think this is some of the data that our team is producing based on a project called the Launch to Scale Speedometer, which is how long does it take for critical intervention or innovation to receive regulatory approval. And so I think this essentially does have a number of the COVID vaccines, and you will see that this was, regulatory approval was quite fast. But then the orange, the last three legends, how soon or how quickly are these vaccines able to be taken up in LMICs? That's actually, very slow. And so that global picture really reflects, those, high-level statistics from the WHO. And so some of the reasons have been, a reliance on donations and limited channels for countries to procure, even when they don't want to procure. And we'll sort of look at that in the next slide. Then, of course, supply chain disruptions and delays. I think those of us on the call may recall what happened when India was facing its last wave and limited export of the AstraZeneca vaccine, and it was a primary supplier to the COVAX facility. And Africa, in turn, was really reliant on COVAX to do pooled procurement of vaccines. And so these and similar supply chain disruptions have limited the ability of vaccines to be in country. Then limited manufacturing capacity. So I won't dwell on this so much because we do have a slide on it. And then, of course, challenges around last mile distribution. However, on this, I think the picture is mixed. Whilst, of course, there have been challenges around making sure that anyone who wants to be vaccinated can receive a vaccine, there's also been some promising innovations, which I will highlight towards the end of the presentation. So on to vaccine donations. So the country I live in, Kenya, is our COVID vaccine program is almost entirely reliant on vaccine donations. And so one of what I would want you to take away from this slide, it's quite data rich, is that whilst there have been a lot of pledges of vaccines from high income countries and countries that are producing vaccines, most of the pledges have not been honored to date. And so that, I think, also impedes the ability of countries who have nowhere to buy and essentially have to rely on the goodwill of other countries. And when those pledges do not come on stream quickly enough, and especially also when countries have made some basically changes in their vaccine policies, so introducing boosters and which then now reduce the availability of doses to be donated, that poses a problem. So then onto the manufacturing capacity. So currently there is no African country that is doing local manufacturing of COVID vaccine, but there are 2 sites that are providing fill and finish. And so we've highlighted them. So Aspen in Port Elizabeth, South Africa is doing fill and finish for Johnson & Johnson and has been producing doses since 2021. And then BioVac has been contracted to do fill and finish for the Pfizer and BioNTech vaccine, but then production is only coming online in 2022. And so that means that there's very limited vaccines actually being produced on the continent. There are, of course, some initiatives that are trying to address this. So then partnerships for African vaccine manufacturing, the PAVM, is an initiative that was recently launched by the African Union and the Africa CDC. And that, I think, has some promise. However, of course, there is a time lag between, being able, to set up a manufacturing site, bringing online, and have it actually produce vaccines. And so that, I think, is something that will continue to hamper vaccine rollouts. And so based on our team's analysis, I think there is definitely, the data suggests that there needs to be rapid development of regional manufacturing hubs, including 3 to 5 on the African continent. And I will share updates on this towards the end. And then, so what are the promising approaches that we see? So what we have seen has worked, and I think the previous 2 presenters have talked about this: political leadership and fiscal prioritization. And so receiving the vaccines is one thing, but then there also has to be resources dedicated to rolling out the vaccine in the country. And so one of the countries I want to give an example of is Kenya. So for example, our vaccine program, I think, was rather sluggish until the president actually made a speech where he declared and set a target that 10 million Kenyans need to be vaccinated by the end of 2021. And that essentially meant that all the arms of government then rallied towards that target. And so I think we've seen that both in other countries where the political leadership, when it has changed, or existing political leadership has driven, vaccine rollout. Rwanda, I think, is another example of this. And then I think what has been promising is that a lot of African countries have, well-established vaccine distribution mechanisms and vaccine programs. And that has been leveraged to be able to then distribute, store and distribute the COVID vaccine. And then I think also technological innovations. This has been quite useful in tracking uptake. So for example, in Kenya, I think we have maybe 4 or 5 different vaccines available because, again, like I said, we are relying on donations. And so the Ministry of Health with its IT team developed an application called the Chanjo app, which basically is able to track which vaccine an individual has received, send reminders based on the scheduling, and essentially be able to provide up-to-date real-time data to help us know what's the vaccine uptake numbers are. And then another innovation is Project Last Mile, which is a collaboration with Coca-Cola, which is using its cold chain and logistical prowess to be able to support last mile distribution in South Africa and Eswatini. And this was actually quite interesting because Eswatini, I think, did have some conflict earlier in the year, but they still, with using that Coca-Cola distribution chain, this really did not disrupt the COVID-19 vaccine distribution as much. And then I think local manufacturing capacity. So a recent announcement is that Rwanda and Senegal have signed on to become the first two manufacturing sites for COVID vaccines. And whilst this, I think, is great, we see this really more in supporting longer-term availability. So, when boosters need to be availed to the broad population, when there's vaccines for the next pandemic, and also as a means for meeting ongoing needs for the standard vaccines. Then finally, I wanted to share, something else that our team is doing. Recently announced initiative that's Duke-wide. With other centers across DGHI, which is the COVID Gap platform. This is a collaborative platform with 10 African countries to be able to monitor progress on vaccine rollout and enhance accountability. Like you remember from the slide on donations, it's one thing to announce that you will donate. It is one thing to say that countries in higher income countries support vaccine equity, but it is yet another to be held to account on those promises. And so one of the things that this platform has done is produce a policy brief for the recently ended G20 Leaders Summit. So then calling those leaders of high income countries to be accountable to basically ensuring that there is global collaboration to manage and end this end this pandemic. And so, those are some of the promising approaches that we've seen. Yeah, so thank you.
Thank you, Patricia. Now let's hear from Lavanya.
Hello, everyone, and thank you for the opportunity to present today. In the next 10 minutes, I'm hoping to talk to you about vaccination barriers and vaccine hesitancy using Tanzania as an example. So the World Health Organization defines vaccine hesitancy as a delay in acceptance or refusal of vaccines despite the availability of vaccine services. And I highlighted this phrase in orange to help you remember from Dr. Odero's presentation, the severe bottlenecks we have in COVID-19 vaccine manufacturing in Africa. Vaccine hesitancy is actually a continuum, where on one side you have people who refuse all vaccines. So these are individuals who are often referred to as anti-vax. And then on the other hand, you have people who accept all vaccines and tend to be vaccine champions or pro-vaccine. But in the middle, you have this whole spectrum of individuals who tend to accept some vaccines, but delay or refuse others. Vaccine hesitancy is highly contextual. It depends on where people live and their circumstances. It's also highly time varying, and it may not come as a surprise to you if I say that vaccine hesitancy tends to go up anytime there's a pandemic or a new vaccine that is approved. And vaccine hesitancy can also be very highly vaccine specific, especially for the population that falls within this purple rectangle of refusing or delaying some vaccines. Those are individuals who have concerns about specific vaccines. WHO also has this really nice detailed framework that describes the determinants of vaccine hesitancy, and they group determinants into three big buckets. So on one hand, you have contextual influences. So these describe local politics or policies, geographic barriers. communication and media environment. So this is where vaccine misinformation would fit in. Then you have individual and group level influences. So these include people's own experiences with vaccines or vaccinations, or those of their loved ones or friends. Then there are risk-benefit trade-offs that people are making in terms of how risky they think the disease is versus how beneficial they think the vaccines are going to be. And then there are vaccine and vaccination-specific issues, which are really broad and encompass everything from how the vaccine is manufactured, what the formulation looks like. So you may remember a lot of concerns with the mRNA component of the COVID-19 vaccine, how it's administered, reliability of source and supply, and so on. So for the last 6 years, I have been working in partnership with colleagues from the University of South Carolina and the National Institute for Medical Research to look at vaccination barriers and vaccine hesitancy in Tanzania. Although our research is focused on childhood vaccines, I think as I describe barriers to you, you will notice a lot of parallels with COVID-19 vaccinations. So in Tanzania, 1 in 4 children miss out on recommended vaccines in the first year of life. And there are tremendous geographic variations in vaccine uptake. So the darker red regions here indicate higher vaccine uptake regions, whereas the lighter yellow regions indicate places where vaccine uptake is low. This is the Tanzanian routine childhood vaccination schedule. So children receive 6 vaccines before the age of 1 that protect them from 11 diseases. And these vaccines are recommended according to a specific schedule. So you can see they're timed at birth, 6 weeks, 10 weeks, 14 weeks, and 9 months. So in our collaboration, we looked at the timeliness of vaccine uptake according to the schedule. And timeliness is a great indicator of the performance of routine vaccination programs, because any delays or gaps in vaccinations reflect vaccination inequities and vaccine hesitancy. So we looked at vaccination uptake in a cohort of 144 kids. And this diagram basically describes timeliness of uptake in those kids. And so in the kids that we looked at, there were a small proportion of kids who were never vaccinated. A large proportion of them started timely at birth, but by 1 year of age, that proportion had significantly reduced. And then there was this big group of kids that remained that had received delayed vaccinations. Now, what this meant was if there was an outbreak of a vaccine-preventable disease between 14 weeks and 1 year, all the kids who are in this yellow and red region would be susceptible and not protected. So we started diving deeper into reasons for delays and lack of vaccinations. And so we asked the mothers of these 144 kids some questions about their beliefs in vaccination. So we presented them with several true or false statements. The first set of statements were about their beliefs around the importance and benefits of childhood vaccinations. So the green bar represents positive beliefs. The red bars represents negative belief, and the gray bars represent responses where the mother said they were not sure whether the statement was true or false. As you can see in this slide, mothers had overwhelmingly positive beliefs about the importance and benefits of childhood vaccinations, and many of them strongly believed that vaccines prevented diseases and were important for their kids. But as we moved on to asking them questions about vaccine safety and efficacy, we started to see more and more mothers express negative beliefs. So things like, are you confident? How confident are you about the vaccines that your child receives are safe? There were a lot of moms who were unsure. Confidence in the effectiveness of vaccines. Again, a lot of moms were unsure. Side effects, we saw more moms who had negative beliefs and so on. And finally, we asked them a set of questions that asked about their knowledge in terms of vaccine administration and the need for multiple vaccines. And this is where we saw some of the biggest knowledge gaps. So things like, my child does not need vaccines for diseases that aren't common anymore. We saw a lot of negative beliefs. We saw gaps in knowledge about the need for multiple doses of vaccines, and that vaccines can be co-administered with other vaccines. And these have implications for COVID-19 vaccines, which are multi-dose vaccines and potentially require boosters. So we took those true or false statements and created a vaccine hesitancy index. And then we compared women who lived in rural areas to those who lived in urban areas. We found that women in urban areas, shown here in the purple peak, typically had lower vaccine hesitancy, whereas women in rural areas, shown here in the red or pink peak, had more vaccine hesitancy. In fact, in our sample, 72% of the moms reported missed or delayed vaccines, and 79% reported at least one vaccine-related concern or knowledge gap. We used other methods to look at the value that people place on vaccinations. And so we used a method called willingness to pay. It's a method used commonly in health economics. So basically, the more you're willing to pay, the more value you place on a good or service, which in this case would be vaccinations. So in this first box, we saw that as families were wealthier, we saw an increase in the value that they placed on vaccinations. And that's expected. If you have more money, you're willing to pay more for services and goods. But then the second box was the most interesting one to us, where as we saw an increase in vaccine hesitancy using the vaccine hesitancy index that I showed you in the previous slide, we saw this dramatic decrease in the value that people placed on vaccinations. And then same thing with time to health facilities. The further away people were, the lower they valued vaccinations. And so we did some qualitative interviews where these themes around geographic barriers kept coming up, where moms were talking about difficulty in getting to the clinic to vaccinate their kids. Even when they did get to the clinic, there were challenges in the sense that sometimes there wasn't enough gas to power the refrigerators that contained the vaccines. And so mothers who would get to the facility would sometimes be turned away because there was no functional refrigerator. We also found issues with the use of multi-dose vials of vaccines, where even if a mom got to a facility and there was a functioning refrigerator, if there weren't enough kids for the vaccinator to open a multi-dose vials, the moms would be asked to come back on a different day. And so we found that this led to a lot of frustration among mothers. So for example, this mom is saying, I think the idea of telling us to come back another day because we are only 2 or 3 should end, because we have left our activities to come on that day. And so they're asking that they should get the vaccine no matter how many they are. And we also heard some quotes around complacency. So here is a rural mother who's talking about other women in her community saying, so long as they've given birth, then they think that the child will just grow, so they don't care about vaccinating the child. So this talks about value on vaccination. So essentially, there are these multifaceted barriers to vaccination in Tanzania that not just reflect the immunization system and service and reliability, but also gaps in parental knowledge and attitudes, which result from gaps in information and communication. And as I mentioned, there are family characteristics like family wealth and residence, transportation options that also factor into whether or not somebody gets vaccinated or when they get vaccinated. So people in places like Tanzania are making trade-offs between the long-term benefits of vaccinations and the short-term barriers that they face. And oftentimes we find that the scale is tipped towards the short-term barriers where they have, they're not able to access vaccines, they don't have enough information, they have negative attitudes, or there are supply side issues. And what we are trying to do with interventions is basically tip the scale the other way. And we have tried interventions that have used reminders and conditional financial incentives successfully. We have also implemented community health worker-based interventions for educating mothers and are finding some success there. Just putting all of this in context, I have been involved with the global survey conducted by the Center for Policy Impact in Global Health, which is a center within the Duke Global Health Institute, where we asked global stakeholders about barriers that they expect to reaching the population in their respective countries. And if you look at the Sub-Saharan Africa group here, the biggest barriers mentioned by the stakeholders were related to geographic barriers, cost-related issues, supply chain, shortage of supplies. Vaccine hesitancy is the small gray bar here. But I suspect that's only because of these large looming barriers around supply of vaccines. Just a quick mention that with COVID-19, the disruption is not just limited to COVID-19 vaccine distribution, but also vaccination for other childhood and other routine vaccinations. At the start of the pandemic, 41 countries suspended measles vaccination campaigns, and right now there are several active measles outbreaks in progress. So just to summarize, we are implementing COVID vaccines in a context where there was already regional variations and rural-urban disparities in vaccinations. We know that there are vaccine concerns despite knowledge of the importance of vaccination, and supply chain issues cause missed opportunities for vaccination and frustration. And we want to take steps to avoid vaccine hesitancy because it reduces the valuation of vaccination. I'll stop with that, and I'm happy to answer any questions.
Fantastic. So thank you all for these wonderful presentations. And now we can start the discussion. I encourage the audience to speak up and ask questions verbally, to raise your hand and I'll call on you, or to put questions in the chat box. So perhaps I can come back and ask the first question, and this is for each of the panelists. So do you have a sense that morbidity and mortality from COVID in Africa is truly lower than expected? Carl, perhaps you can go first.
Thanks, John. I think it is a representation with the barriers of testing. Still, it is a representation of what's going on, because first of the population sort of dynamic and the population structure in Africa. We know the median age in Africa is around around 16 years old, 16 to 19 years old, compared to 42 around most high-income countries and developed countries. And the huge youth population bulge means people are mostly asymptomatic, and mostly the youth population don't manifest with any symptoms or do not easily get in terms of mortality now. And also the huge population of people who get COVID and die are above 65 years old. That's one. Another sort of hypothesis that comes with it is around how Africa has already been prepared to deal with non-infectious diseases. Africa already has the African network of novel viruses, great leadership from CDC, handling outbreaks. So that's also something that really in the early stages of the outbreak had good control of how the sort of the spread of the pandemic itself. So I think it is a representation based on the youth population, based on that previous sort of preparation and preparedness of African sort of networks and health and sort of health infrastructure when it comes to outbreaks and diseases.
Excellent. Okay, so we have a question in the chat box from Chris Paul. And he asks, what examples and information do we have on COVID disease impact in distant and rural populations in African countries? From my colleagues, including in Mauritania and Ethiopia, I have mostly heard of adverse secondary impacts from shutdowns and economic restrictions. Patricia, do you have a comment on this?
Sure. Thanks, John. Yeah, great question. I think there's definitely, even in Kenya, I guess we've had until quite recently, a series of lockdowns. And so there has definitely been, economic impact. And that has, that of course has, affected, for example, as Carl had mentioned, access to education, access to, nutrition and other health services. And so I think those impacts, will be felt, into the medium term. But again, I guess a lot of countries, especially when there were no vaccines available, were trying to figure out, how do you limit, how do you enforce social distancing? How do you limit mobility, and etc. Yeah. And so I think it was really a balance between the two.
Excellent. Okay, we have a question from Lucy Chiquetu, and she asks, do you think the shortage of readily available data on vaccine adverse events is a factor in vaccine hesitancy? Why is this data not readily reported? Where can people get these data? And perhaps Lavanya can handle this.
Yeah, I think there are different systems based on where you are that report adverse events. Of course, in the US, we have systems like the VAERS database where adverse events are reported, but this kind of data is less readily available to the public in some of the settings that we are talking about. I think the bigger challenge is that of vaccine misinformation. And this has been a challenge, not just for COVID-19, but for other routine vaccinations as well. The increase in social media presence in some of the sub-Saharan African countries is leading to a spread in vaccine misinformation. There are lots of myths about, for example, reproductive effects of the COVID-19 vaccines that we've heard before with other vaccines, but are being spread. And we are seeing this gender gap in, whether men versus women who are getting vaccinated. I think also reports from other countries like South Africa, where there was this whole fiasco with the AstraZeneca vaccine. So some of those reports are also, I think, factoring into people's fears about getting the COVID-19 vaccine.
Okay, thank you. So we have a question from Skylar Knowles. Is there any public perception among Africans that vaccine pledging governments or organizations are withholding delivery until their own interests are advanced? Or more generally, how is the general population reacting to vaccine supplies? And perhaps that question should go to Patricia.
Wow, that's a loaded question. I think, because I think it's health diplomacy. Of course, there is nationalism around any scarce resource. But however, I think there is a strong advocacy platform being led by especially African institutions. I think the WHO Director General included and other global organizations are really calling for vaccine equity. And I believe that probably is what we should focus on, because then, how do we make sure that, because it is what it is right now. The supply chains are limited, there have been disruptions, but then going forward, how do we then support greater vaccine equity? I don't know if the other panelists want to make a comment.
Okay, so we have a next question from Jeff Gingrich. He says, what I hear the most from my contacts in Sierra Leone is skepticism about the only available vaccine, which has generally been the Sinopharm vaccine. They feel like they're being offered an inferior vaccine. So perhaps Patricia, I hate to keep putting you on the spot, but do countries have a choice which vaccine they can use?
Well, I think yes and no. I guess it's also, some of this, donations are bilateral agreements. But then, for example, just using my country, Kenya, at some point, it just became clear that we had to distribute what was available. And that's why, for example, like I said, we have at least 5 different vaccines in circulation. And the role of the Ministry of Health has been to educate people that, this is what's arrived in the country. So there's been a lot of mass media information on vaccine donations coming into the country, and also education, public education in terms of, this is a vaccine, it's as valid as another. And then, of course, use of technology to try and make sure that people are aware, of the differences. So, for example, in terms of the intervals for multi-dose vaccines.
And if I can just quickly add one more thing, I think this also speaks to the need for increasing regional capacity for vaccine manufacturing, because in that determinants framework, under the vaccine and vaccination specific determinants, source of the vaccine is a big factor in driving vaccine hesitancy.
Interesting. So I think we've gone past our hour. So I'd like to thank all of today's presenters, the audience, and Meredith Watkins for her help with organizing this session. There continue to be questions in the chat box, but unfortunately, we're out of time. So, Kevin, perhaps you want to make a closing statement.
Yes. All that information was wonderful. So thank you, John, Patricia, Lavanya, Carl, and Alex. And thank you all the attendees who joined us today. So next week at Wednesdays at the Center continues with Mr. Mark Driscoll of UNC Chapel Hill on a talk entitled Blacks, Weather, Whites, Climate. That'll be next week at Wednesdays at the Center. So thank you again, and we hope to see you next Wednesday. Okay, have a great day.
Thank you.